Great. Thank you for coming. Welcome, everybody, to this year's, unfortunately, virtual HARC meeting. But nonetheless, this is HARC 13. So it's hard to believe it. But actually, we've been having HARC now. This is the 13th year. Really happy to start this session with Kathy Mead. Today's keynote is Kathy. She's really been a stalwart, a very active person in the whole health literacy community and health literacy research arena. Had in the past has run her own conference in this area, really connecting health literacy and culture and cancer in particular. But before I introduce Kathy, I do have some housekeeping notes. The timing is a little tricky in these virtual meetings, hopefully people will see that they have in the live event page that there's links for the different sessions. You may have to now and again relaunch the live event page
you can see.
Just to make sure that that everything's working. I've noticed that if you go to the poster link on the live event page, which I do recommend that you do, that you then, when you go back to the main agenda, you may have to relaunch the live event page. Mm-hmm. Another couple of notes. It's hard to do networking in a in a virtual meeting, but we are going to be trying to do that. There's a networking session that's tomorrow, and I hope that people will come. It's one of those things that are particularly hard to do when you're not in person. A few more notes about the posters. Many of the posters actually have linked videos from the authors. Please check those out. And also, if you go there, you'll see that there's a link. You can vote for the best poster of the conference. You have your top 3 votes. Voting closes tomorrow at 3 p.m. and there will be a prize for the best poster. Evaluations, there you will get, we're just starting, but I have to announce this multiple times. You will get an email for that. In general, if things seem to not be working, check your email or the website if there's technical issues. With that, I don't want to take any more time from Kathy. So Dr. Mead is a behavioral researcher who's really been very committed to community engaged research, and in particular oriented for patients with cancer. She is a fairly well-known health literacy recidivist, like some of the rest of us. But if you're new to health literacy, I think you're going to really should learn about her work. And if you've been in here a long time, this is a very nice time to hear Kathy kind of explain where she's come to it with this. And with that, I'm going to stop and say, please, Kathy, take it away. But you have to unmute.
We are, okay. Go back to slideshow. Okay, good morning, everyone. It really is a delight to be here for HARC number 8, believe it or not. And first, let me commend Michael Pash-Orlo and his outstanding team, including Lori, for planning this conference. It does take a lot of work, but really what is most important is that it's keeping the topic of health literacy in the forefront of our minds. Never before, as we enter the 20th month of the COVID-19 pandemic, has messaging and clear communications been as important today in our national climate, as well as our continued focus on health equity. You really will be in for a treat over the next 2 days with this conference. There's a number of topics covering healthcare access, decision-making, HIV, HPV, a great deal in the area of infodemics and technology. And today, as we start off and kick off the conference, a topic that is dear to my heart, and that is community engagement. First, let me share that as I thought about this presentation, when Michael first asked me, and my involvement in numerous health literacy initiatives probably over 3 decades, I kept thinking about health literacy, of how it has evolved over the years, how the definitions continue to change, how we continue to conceptualize it, how we continue to measure it. So I'd like to bring us back to the community and bring us back to our patients and our families, because even though they may traverse through our clinical settings, We all go back home at some point, where we work, where we live, and where we play. So I'd like to give you sort of a snapshot of my journey in the area of health literacy, how it has influenced the research that my team and I conduct, and really begin to share with you of charting a course toward community engaged research. What shall I pack? So think about that for a moment. What will you pack? When you go out in the community, will you pack a phone? Will you take your coffee, a compass, snacks, a toothbrush, which we have found to be very popular items to go out when we journey out into the community? So today, what I'd like to do is talk about the essential role of community engagement for building community and research capacity to impact health disparities, keeping in line with the theme of this conference. Unpack the role of community academic partnerships as a springboard to address community concerns. And most importantly, I'm very excited to share with you the Tampa Bay Community Cancer Network experience, which is almost 18 years in the making. Also, two topics, culture and health literacy, how to chart the importance of this in developing evidence-based interventions. And last, what is so important to community engaged research is participatory research, and illustrate through several of our cancer prevention programs how this has played a significant role. So think for a minute, what do your communities look like? Here is a snapshot of some of our communities in the Tampa Bay area. And what you can see clearly is that it's very diverse, it's multicultural, and if you converse with our community members, it's multilingual as well. So for my research program, my laboratory is the community. So think for a moment about health disparities, the topic of this conference. We know there's no single cause and no single solution, but we want to strive for health equity. Certainly in the field of health literacy, we strive to find out, well, will health literacy make all the difference in health disparities? It's really difficult to disentangle health literacy in health disparities. But there are a number of activities and tasks and processes that we can do to implement and really improve the situation. It's important to note what our changing health literacy landscape really looks like. Rapidly changing demographics, blending of many cultures, heightened focus on equity, diversity, and inclusion, greater social internet network penetration, many healthcare and technological advancements, and we see that very often here at our cancer center, the growing need to rapidly respond to new information, which poses increased literacy demands. And again, never have we seen that more with COVID-19, the Delta variants, and so forth. But when you think about health disparities, where is the disconnect? Many of us are involved from a research, practice, or an education perspective of discovery and developing, but the critical disconnect, as outlined by Harold Freeman, who was a breast cancer surgeon in Harlem, was of trying to get the information out in a delivery or dissemination. He was finding a very unacceptable burden of breast cancer and death from breast cancer in Harlem. And because of that, he initiated, many of us know, the patient navigation program, really bringing services directly to the women in the community. So our disconnect is a key determinant of the unequal burden of care. And we really need to play a significant role to deliver that. And where better else to do that but in the community? Of course, and I think you'll be hearing more about this later from one of the keynoters, our social determinants of health. There are many factors and probably many more that have come to our attention from when I started out in the field that play a role in health. But keep in mind two really key determinants, literacy, and then certainly community engagement from the social and community context, areas that we can begin to make an impact. So what does transformational research begin to look like in community engagement? We need to create new paradigms to unpack health disparities and move from description, detection, and correlational to more causation and intervention-driven research. Also, maintain this community and patient-centric lens. And most importantly, begin to invest not only in individual health with our patients and family members, but community literacy education to align the context of individuals, their worldview, with the community knowledge, skills, and resources. This to me is one of the most promising areas that we can put forth our efforts. And I would call your attention to the article by Dr. Jones et al. From Australia, who has really made the case for integrated health and community literacy to really achieve community engagement. So how have we done this here down at the Moffitt Cancer Center and in Tampa Bay? We have begun to create research partnerships for better health and equity. And I'm delighted to share a bit about the Tampa Bay Community Cancer Network, which really represents a community academic model of engagement. So you might ask, where did we focus our efforts? Well, initially when this started, probably in 2005, it was focused in the 3 counties that were most contiguous to the cancer center. Our efforts have now really spun out into 15 other counties, and soon to be, they'll be expanding further as our catchment area also expands as well. So let me tell you about the story of TBCCN. Before 2005, very much probably like your institutions, whether it's a cancer center, a hospital, a clinic, or even a university, community education and outreach is really foremost very prominent. And as you can see here, a picture of a health fair with lots of brochures. We were aware of several new opportunities at the National Cancer Institute to create what was called the Community Network Program. The first round, the first 5 years, was really to very solidly put in place an infrastructure that would build upon community partners partnered with academic partners. This led to the second round of funding and our community network, which continued to develop not only outreach, but research as well as training. Now, you might ask, what happens when the funding runs away? And this is always a concern. Due to institutional support, TBCCN continues, which actually proved very positively as we began to dig deeper into our catchment area research, and we spun off into 4 working groups. And again, these were at the decision of our community partners: screening, survivorship, youth, and HIV and cancer. And I should make note that when we first pulled together a number of community partners back in 2004, we had not written one word of the grant prior to submitting it. We presented the opportunity to see if folks were on board with this opportunity. And it was at that point that we created TBCCN, focused on tackling health disparities. And we would focus on medically underserved with cross-cutting themes of culture and literacy, and not focus specifically on any one particular racial ethnic group. What was key were these 3 pillars that you see on your slide: outreach and engagement, training, and research. And as you can see, each of those pillars involved a number of activities which were joint activities with partners. Probably in total, we had over 18 different supplements of research projects that was associated with TBCCN. And today, TBCCN has continued to leverage other and new projects as well. So really, to give you a flavor of TBCCN, let's hear from some of our community partners. We produced this a few years ago, and I think this will give you about a 4.5-minute snapshot of TBCCN and how it might be helpful to you. Tampa Bay Community Cancer Network, also known as TBCCN, is a group of organizations that have come together to create partnerships for better health. Through outreach, research, and training, TBCCN is working hard to reduce gaps in cancer care. Let's take a look at what TBCCN is doing in your community. TBCCN is providing high-quality education and improving access to useful and easy-to-understand cancer information in many languages.
TBCCN embodies the spirit of partnership. The simple answer is the health disparities that we face in a community like ours are too big for any one of us to tackle alone.
My idea of TBCCN is a whole community of educators and thought leaders and scientists and researchers that are trying to get the word out on health disparities.
We found that we have had better access to educational materials, that they've brought in many different languages and ways in which to approach our patients.
So TBCCN serves a variety of diverse populations, foreign-born populations, underinsured, uninsured, low income. So it pretty much runs the gamut, but individuals who, for a variety of different reasons, may not have access to cancer-related information or resources.
I always tell my students, knowledge equals power. So now we empower them. They have the power to know where to go or where to use these resources. And TBCCN is one of the best.
Researchers are joining with community members to develop and evaluate innovative programs to improve community health and bring advances in cancer research right to the community.
Part of what has come out from the research that I've been doing in collaboration with TBCCN is one of the issues is health literacy. And what we've been able to hammer out over years is an educational program, particularly for our women who don't have a good understanding of their own bodies when it comes to, well, women's exams. So this is a low literacy, high image type of educational tool.
Well, of course, in my community, initially, research was kind of a mystical word that people really didn't understand. And I think part of what TBCCN has done is come in and made it something that people could relate to and show them that this is not a scary thing, that it's really going to help them. I think when they talk to our clients in our community centers, they found out, research is your friend.
So the research that we do in TBCCN is really comes from ideas that come from our community partners. Over the years, we have talked about the health disparities we face in cancer screening and early detection. One particular area of importance is the colorectal cancer screening, where we have very well established tests that we know work and can benefit our communities.
TBCCN scientists and community members are training aspiring researchers on how to best tackle health disparities at the local level in ways that fit the everyday lives of people.
I think that culture is a very important factor to know that when I'm going into the community, I have to understand the community that I'm in and to understand how to approach them, maybe how they speak, what they believe, or how they act, and not come in different, but come in as this is my community as well, and I'm here to help us.
Most of my research and my work in the community is working with Latino cancer survivors. I currently have several projects that really came from my relationship with TBCCN and the needs that Latinos in the community identified related to education, to support, and to programs that are really meaningful to them and that are in Spanish and easy to understand.
We have to get together. We have to share our knowledge, our wisdom, our cultural competencies so that we can reach as many people as possible and really not worry about who gets credit, but worry about the outcome for our community.
Today, TBCCN is helping in the fight against cancer for everyone's tomorrow.
Okay,
I know we have some comments in the chat, but I know when we clicked on it, it stopped it. So I'm going to keep going unless we hear otherwise. So I hope the video has provided you with a snapshot of TBCCN right from our community members. So to advance some of our research partnerships and to really embed health literacy into those research endeavors, we typically have asked 4 questions. First of all, what are and what were the community concerns? And this is often very data driven. How was the community involved, discussion and dialogue? Are they co-leading the endeavor? Are they part of the community advisory board? And what did we do, such as design and develop a program, a research study? And importantly, what were the outcomes, discovery and delivery, so that we can really have impact on the disconnect. So with that, there are really 4 main tenets of TBCCN. And again, whether you work in a clinical setting or wherever, many of these tenets can be quite powerful and influential in your work. While community-based participatory research is really reflective of this orientation to including and engaging end users, community engagement also engages people in the process, inclusivity and trust, and then the 4th pillar, culture and health literacy, making it real. So let me spend just a moment of going over each of these tenets in a quick way. Let's talk about CBPR first.
Kathy, just a half a moment. There's a little black box at the top of your screen. If you could turn that off so we could see the top of your slide.
Thank you. We tried to do that.
Oh, okay, okay.
We're going to try it again.
All right.
But thank you. Okay, how's that?
No. Oh, so now there's just a little box in the middle of the screen. There you go. Now it's good. Now it's
okay.
perfect.
We don't. Okay. Thank you, Michael.
Perfect. Sorry about that.
Thank you. But you heard the video, correct?
Yes. Yes. We heard the video. Thank you.
Thank you.
Perfect. Sorry.
So CBPR typically brings together siloed stakeholders. And what's important is that we can translate ideas and questions into new approaches based upon the health needs and concerns. All right. Here we go. Okay. And what CBPR also does, it provides an EMIC perspective, really an insider perspective, striving for co-creation of knowledge. Now, on the other hand, what is community engagement? And this is a topic that I think all of us, wherever we may be working, academic, clinical, hospital, cancer center, are familiar with community benefit. And it has gained exceedingly high importance, a process of working collaboratively with groups of people affiliated by a special interest, by geography, and involving those partnerships that can motivate people, motivate and mobilize resources, and influence systems. And what I have seen over the years is that community engagement may be as straightforward as outreach to a health fair, involving community members as a consultant, involving them in projects, as a co-collaborator and or shared leadership. Again, some of those nuances are decided upon with your community partners. Most importantly, community engagement is bi-directional. So you might ask, well, how do I get involved in community engagement? I think being visible in the community, and again, one of our signature programs is Ask the Scientist, whereby we have a number of physicians or researchers which go out to community sites to share their knowledge. Co-lead joint activities from a training or mentoring perspective. We had an academic community journal club, which was co-led by both a partner and a researcher, or offer health literacy workshops. What really is more fun and exciting is to co-create and co-lead different types of research studies. In short, it's all about engagement. As I mentioned before, the article by Jones et al. In 2020 really laid out 6 principles that can support community literacy. And the authors did a really elegant job in drawing from Nutbeam's level of health literacy. Many of us are familiar with functional, interactive, and critical health literacy. I see some of our abstracts related to that. And to remind us of the community complexity, that tailoring may be needed, the community context, again, understanding people's beliefs and values. And what is really most important is that intangible development of trustworthy relationships, being responsive to community needs from an education perspective, and also a reorientation, which was music to my ears, to prevention and public health. And last, community solidarity of mobilizing strategic processes that can support some of these operational and redesigned changes that we can do right in our community. Now, culture and literacy also has been two areas that I have been exceedingly interested in, and which are fundamental for effective communication to advance health equity. So we might be able to simplify information. We may be able to make information resonate with someone, but does it resonate and is it salient for their background from a cultural perspective? And these two pieces, in my mind, intersect very nicely. And whether it's cancer or health or some other topic, are exceedingly important. As we know, culture is that socially constructed constellation of practices and schemes and competencies that really inform our worldview, the fundamental beliefs that inform thinking and our decisions. Now, I'm sure we're going to hear a lot about this during HARC number 8, as the definitions of health literacy have been evolving. While we're still very much focused on personal health literacy, which has just changed a bit in terms of its wording, in terms of understanding and using information, but there really is more emphasis on organizational health literacy. And that's the degree to which organizations can enable individuals to find, understand, and use information. How can we apply this out in the community? How can we make our processes more health literate friendly? I think we have a great promise and potential in this area. So what is clear is that beyond the individual, equal attention, and this was probably not the case so much when I started out in the field of health literacy, and was quite a bit of discussion of being watchful and cautious not to blame the individual, but we as providers, we as organizations or government systems or healthcare systems need to take responsibility to expand our influence and redesign processes to support health literacy. This is going to take multi-sector engagement, which is going to be very critical. Harmony among many sectors. And where can we find harmony among many sectors? Of course, the community. ITC, you might say, okay, what is she thinking with this? This is kind of another reminder, and I've used this slide for many years, that we really focus on including our community members, making them feel respected so that they can trust our message before we get to the content. I think back probably when I started out my career in nursing as a cardiac nurse, that was very interested to deliver all the information about, the perils of smoking and overweight and bad nutrition. But to get to that content, just like in any other field that you all may be in, we need to lay the groundwork, just as we do with community members, to create trustworthy relationships. As you will know, TBCCN did not happen overnight. It's really been a process over almost 2 decades. So get real with culture and literacy. We came up with a mnemonic called The Real, of making our information and messages not only relatable, but engaging, actionable, and literacy friendly. Now, these are some of the materials that can be viewed as in upcoming slides when I talk about some of our studies in English and Spanish and Haitian Creole. So we need to be creative. We need to be responsive to our community members so that they hopefully can do something with the information, or it can support the behavior that we're most interested in. But let me tell you, the real health literacy teaching tool is this. And I'm going to talk to you about our work in the area of colorectal cancer. And believe it or not, these little portable potties that you can buy at some of your local stores is one of the most powerful teaching tools to demonstrate and to allow people better understand of how to use a fit test. So again, think about the community, think about the needs of the community, how you can engage in conversations. And these conversations take place at many of these health events, many of their own activities, and to have a sit down with them of what's on their mind, what can we offer in terms of our knowledge from a cancer center, an academic center, a physician perspective, a nurse perspective, but together, how can we collectively be much more impactful? So TBCCN and our community engagement efforts have strengthened our community capacity to build research infrastructure. Now, some of your areas of interest may be depicted on this particular puzzle of slide. One of the areas that we've been most interested and concerned about is in the area of cancer screenings. So here's a quick question just to kind of change it up a bit. What percentage of deaths could be prevented with colorectal cancer screening? I hope you thought of 60%. So over the years, we have conducted a number of TBCCN community-driven colorectal cancer screening studies. The ones that have the red stars, I'm going to just highlight. And what I'd like to do is highlight for you how we've embedded and infused health literacy into these studies to achieve some type of a desired behavior. So again, our first project, which was was drawn from the original TBCCN, was the CARES project, colorectal awareness, research, education, and screening. Of course, the first question is, what was the community concern? So at the time when we thought about conducting research, because this needed to be part of the original application that we submitted, we had done a lot of work in the area of prostate cancer and breast cancer, but not so much on a cancer that affected both men and women. Also, as we know, colonoscopies are expensive. We've done some tallies, and some of them in the area are up to $5,000. CRC is one of the leading causes of death in the United States, also one of our leading causes of death here in Florida. And importantly, tests were underutilized in our federally qualified health centers. At that time, many of our health centers were using the 3-card GUAIAC study to test for blood. So we embarked on this project, and we embarked with several of our community clinics as partners in this project. And keep in mind, here in Florida, our colorectal cancer screening rate was around 44%. You probably can see where your state might fall up. So this falls way below the metric that we want to aim for, which is more toward the 80%. So our main objective was to improve colorectal cancer screening uptake with the fecal immunochemical test, the FIT test, and investigate some of the differential impact of a multi-component program versus a standard non-targeted intervention, which was the CDC brochure. So with most of our studies, we create a community advisory board of community partners, including our federally qualified health centers, as well as many of our patients from the community. Our research often starts with solid formative research to really get a sense of what providers and patients are aware of on the topic. And just to give you a sense, we found that low CRC knowledge, limited screening, but there was this high receptivity to the FIT test, and the providers especially liked the idea. Interestingly, and not surprisingly, one of the most common reasons given for not doing colorectal screening was, my doctor never talked to me about it. So we began, based upon the formative research, which was quite extensive, created what we called our real tools, our booklet, our DVD, CD, and we embarked on several rounds of learner verification. Thank you to Len and Cece Doak for bringing that technique to our knowledge. So as we infused health literacy in our work, and you could in your work, getting that relatable, engaging, actionable, and literacy mindset, engaging your users, and also being very systematic and conducting formative research, we embarked on developing the tools. Through a process of deconstructing and chunking, and somewhere along the line found that the portable potties were also a very good teaching tool, and building in a number of feedback loops. And in each of these steps, health literacy was tightly infused in a consideration throughout the process so that people could understand the information and act on it. Just to give you another sense, as we created the formative research, we wanted to map a number of the constructs that came from the formative research. And our theoretical framework was based on the preventive health model. So cancer, worry, or social influence. So based upon a finding such as patients being fearful of a diagnosis, we would then create scripts and outlines and storyboards that advance the brochure and the video script. And as you can see here, we identify the construct, we identify the finding, and then at some point we will identify how we're going to address it in the educational material or the intervention on a certain page number or the script. And we did this for a number of constructs. This is just a sampling, as well as for critical health literacy. It was very difficult for patients to really understand how to use the kit and how they could actually complete it. I mentioned before the process of learner verification, and if you haven't heard of this, the Teaching Patients with Low Literacy Skills, while it's not in print, is available in a full text on the Harvard Health Literacy website. It's a wonderful resource, and it really details of how you can verify a number of elements such as attraction, comprehension, self-efficacy, cultural acceptability, and persuasion. And I would highly recommend this, and this really can sharpen your interventions. So just to give you kind of a visual snapshot, you can see as some of our intervention began to move from draft to more complete, we found that patients wanted to have kind of a photonovela type approach for the information to be presented. And then what did we do next? We did a RCT of about 416 patients that were randomized either to what we called the photonovela DVD or CD booklet with mailed reminders versus the standard CDC. Now, I will say that both intervention groups received a free FIT test. So I think one of the lessons we've learned throughout the past decades is that as you embark in health disparities research, you really want to be able to provide the service and the access for your patients. So just to give you a sense of some of our characteristics, kind of a nice blend of female and male. This particular study, our first study, was only English speaking, but we did do a follow-up study, which I'll share with you in a moment. Education, less than high school, about 24%. In terms of income, less than or equal to about 10,000, 63%. In this particular study, we used the realm that was revised, the 8-item tool. And our health insurance, 39% did not have health insurance. Only 7% were born outside the US and 69% had not had any prior screening. So what did we find? So we know what we're striving for. I want you to take a look at the left bars, the CARES Clinic 1 and Clinic 2. Our baseline CRC rates were around in the 18 to 35%, which obviously is low. The national average was around 50%, and at the time, the 2020 targets was 70. CDC's target was in the 80%. We were able to achieve 81% in looking at both of the arms. So the question you may be asking now, okay, so you took time to develop the photonovela. What was the difference? Well, we did not see a difference between our comparison or our CARES arm. And actually, you can see even the CARES arm, there was a slight drifting downward in that. So we did not see a significant difference between the two arms, though overall, we had this 80% achievement rate of screening. So we knew we were onto something. So what did we learn, and what do you take away with this? Well, high fit uptake regardless of the type of materials provided. So might this mean that materials or the type of materials may matter less than access, which could be the key driver in our health disparities research? This also opens the door that clinics have an option in selecting materials. We did find of all the predictors that health insurance or the lack of health insurance was a primary predictor of uptake. But we also realized that we needed to continue to focus on repeat screening. The real key here is that from a practice and a system perspective, our clinics adopted the FIT. They went away from the 3-card GUIAC measure, and this helped them to boost their UDS, or what we call the Uniform Data Standards, which is an important metric, especially for federally funded, federally qualified health centers. As expected, we continued to have a need for Spanish language materials, which led us to the Latino Cares Project. Again, because Latinos, at least in Florida, accounts for about 23% of the total population. Most importantly, when we set out to do the CARES study, it built on TBCCN's priorities and, importantly, the promise to the community that while we couldn't do everything in the first study, we would come back and circle back to Latinos. So again, the difference here is that we adapted and transcreated our educational intervention, and then we conducted a pilot RCT in our clinics with 76 patients. So this gives you sort of a glimpse of what our diagram looks like in phase 1 and phase 2, probably a little bit more complete than what I shared in the CARES study, of the formative research, the transcreation of the materials, moving into the pilot RCT, with the goal of yielding a relevant Spanish language screening intervention. But I think one of the questions to ask here is, why do you adapt or do you transcreate? Why not just translate the information? Well, simple translation simply is not enough. We need to translate and culturally adapt. It makes practical and scientific sense for a new audience while maintaining some of the core elements. And again, it can speak to cultural and literacy relevance. If you look at the model on the right, the figure, transcreation really brings in an emotional connection as well as language and culture. And we spent a great deal of time focusing on this, engaging our users in the process, incorporating them in the research as well. So what you might note before, and attraction is one of the learner verification elements, is that even as the cover took shape and we began to incorporate some of our findings more from a familialism perspective. We told a story of a photonovela, but it was a much deeper story of a family and the parents who were in need of getting colorectal screening and their kids and how important it was. You can see here from a comprehension standpoint that as the materials began to develop, they moved from perhaps not as clear, and then in the far right, you can see where different polyps were highlighted and call outs, which really helped patients understand the information better. So just to give you a snapshot of some of the characteristics in this small pilot, of course, they were all Latino, Hispanic. Interestingly, most were foreign born, probably over 90%. A few more females than the CARE study. A bit lower in terms of years of schooling completed, 43%, their highest level was 6th grade or less, and a higher level of individuals who did not have health insurance. In this study, because we found in some other prior studies in our patient navigation studies, some of the health literacy tools did not translate well, and we switched to using single item literacy questions such as confidence in completing health forms and reporting difficulty in reading health materials. What's kind of interesting in these two findings is that a lot of the participants reported confidence in health forms. Were they getting help in filling those out? However, 47% reported the difficulty in reading, so a lesser amount. In this study, while the overall fit uptake was higher, 87% on average, the patients in the intervention with the trans-created material was 90% fit uptake, and the comparison of 83%. Again, there was no significant difference, which may be related to our sample size, but there did seem to be a trend that with the Spanish language material, perhaps the information was in a more salient manner and resonated more with the population. The Latino Cares intervention arm, trans-created arm, had increases in awareness and susceptibility. On the other hand, cancer worry increased more in the comparison group. So as you look at this, you say, okay, so what really is the take-home message here? We were able to reach a high overall fit uptake, approaching some of our national standards. We were able to reach medically underserved populations, which was always a point as one embarks on health disparities research. I think what we're seeing is that access is really quite important in this type of work. Perhaps the type of material doesn't matter as much. However, I will say that our community clinics and our patients anecdotally like the tailored and personalized materials better. What is clear is that repeat screening needs to be focused on more heavily, and that this is very powerful in impacting some of the practice points in our system. So the very last study that I just want to introduce briefly, and this is where our current line of work is going, is called the CARES REACH study. And this CARES REACH study is based upon implementation science, and it's really moving some of what we've learned into clinics, new clinics, and also clinics in more rural areas. So we wanted to speed up the adoption of CRC screening in clinics in Central and Southwest Florida. And you can see our nice little cap with our fit test. And we're using a stepped wedge design with extension for maintenance. So we have 14 clinics, and we'll be waving in 7 in our first wave, and then the others will be coming in wave 2. As part of this intervention, this involves the provision of a fit test, provision of education, and clinics have the option to use the materials that have been developed or to use other materials. And we're also going to use a coach or champion intervention. So as you look at implementation science, this emphasizes real world relevancy. Did you catch me going across the waves? I hope. It involves the delivery of a core set of EBIs, building on some of the features that to achieve sustainability. And it's really guided by implementation science to move this out to the clinic so they can begin adopting it. And as we look at these multi-level activities, we're going to be investigating throughout the 5 years, we're now in the second year, what patient factors get in the way of screenings, what organizational climate is like, and what tools can help track fit, and how might what we're calling the champion. And let me spend a moment on what the champion does. This was really an idea that as we began to talk to a new set of community partners, they thought, wouldn't it be wonderful to have a champion, which is an organizational change agent located at each of the organizational systems. And they would have oversight from the organizational perspective. They would have close contact with the providers and also be able to coach patients as needed. As part of the study, we are supporting that endeavor with a provider or a champion at each of the sites. The goal from the clinic perspective is that if this proves to be very successful, they would like to apply this to other chronic disease management systems. So what's the potential impact of CARE's reach? It can achieve community and organizational benefit, hopefully access to screening and education for patients. It can continue to ensure uniform data system measures, those QI indicators, which are so important to our clinics, assist in meeting some of the managed care insurance expectations. And again, as I just mentioned, having a champion in place that could be transferred to the management of other health problems. Currently, on a biweekly process, we are having what we're calling our champion chats. And we're trying to work out some of the organizational processes like the EMR triggers. What are things that can make your organization more health literate friendly? So we're hopeful that over the next, 3.5 years, that we'll be able to see some changes, and these will be processes that the organizations can leverage and put into place. So stay tuned on that. So as I'm nearing the completion of my presentation, you might be saying, well, what are the key lessons learned for charting a course of community engaged research? Well, access and sustainability are really at the forefront. Keep a sharp focus on access to care, access to the services, whatever that you're trying to achieve in terms of the behavior. And after your grant goes away, don't let your ideas go away. Keep in step with your community partners and your patients. Forge community academic partnerships to identify health needs, priorities, and assets. We can find the answers in the community. Aim for co-learning opportunities and shared leadership. Implement a variety of participatory approaches. You'll learn a lot. I think one of the lessons I've learned over the years is acknowledge what one doesn't know and be open to learn from others, and be open to learn a lot from others, because humility really counts. Make your interventions relatable, engaging, actionable, and literacy friendly. Infuse health literacy throughout your research in the community, in the patient care setting, in the clinic. And chart a course, importantly, of responsive research to the needs of your community members, your patients, and your families. So what do I pack? It's really, in my mind, quite simple: trustworthiness and humility. The suitcase doesn't have to have a lot of tricks and toys, but just trustworthiness and humility. And most importantly, that starts from a conversation. So again, as I conclude, think of your community, think of the many different terms that I've highlighted throughout this presentation and begin to think about how you can infuse health literacy throughout your research endeavors through community engagement. I thank very warmly, with much gratitude, to many team members and members of our advisory committees and TBCCN who have generously shared their ideas to tackle health disparities in our community. And so with that, I'll leave you with a nice scene from one of our local sunsets here in Florida. And at this point, I think we probably have a few moments to take any questions, comments, reactions that you might like to share. So thank you so much.
Thank you, Kathy. Thank you for taking us through your work. It's impressive and great presentation over the course of this last period. A lot of questions came in. We don't have time for all. I'm going to just choose a few. One question I think that really could help frame several of people's comments is a commonly used word in your talk is the word community. And maybe if you could talk about how this is kind of operationalized in your thinking, and then also how that was affected by COVID.
Okay. So how do I operationalize community? In most of my work, community are community partners that may be organizations, civic service organizations, they may be individuals per se. However, if you're a practitioner who's based perhaps at a hospital setting or a clinic, your community might be your patients and your family members within that community. So I think there's many ways to define that. My space is our individuals that are probably more driven out in the field. In terms of COVID, a number of our community-based projects were affected by COVID, and some of them had to pivot to be consents via by Zoom or messages delivered by intervention. We were at a point in our research that we were doing follow-up by phones, so we were not as affected by COVID, but I would say that a number of our researchers here had to pivot quickly, and some projects for sure did get stalled with that. What that has placed is that we were not able to go out and have a lot of these conversations in the community. We had to create kind of interesting and engaging Zoom opportunities, which, as you know, are not ideal. The question that you saw, the multiple choice question, we had to implement a variety of those little creative things to keep people interested and engaged as well.
Great. So maybe another thing that relates to different types of community organizations or community groups, or depending on how these things are defined, if they're geographic or if they're defined in culturally or other types of ways, linguistically. If you could talk more about the champion role and how people come into this, how that works out, this all happens differently if someone's been told that they're in that role versus is motivated into that role. I don't know if you have thoughts about this.
Sure. So the champion, or coach as we call it, is really individual that has been identified by the organization that we're partnering with. So it's not someone who's employed by our organization, but it has been mutually agreed upon by the clinic that this is an individual who will kind of be the ears and the eyes of the organization to really keep the landscape and the lens on colorectal cancer screening at the clinics in that first wave, and then as it moves to the second wave. So it's very much came forth because of the community partners. And that was really their idea to have that. And so we incorporated that in as one of the features.
Okay, so last one, because unfortunately we have to go to the next session. Yes. Which we'll let the next session start 2 minutes late, not 1, but 2 minutes late, so you have a chance to answer and people get a chance to move over. So you've been doing this work with CBOs in various contexts. But what's your thought, kind of reflecting on this trajectory? What's it going to take to get health systems to actually care and to buy into this agenda?
Well, I think a number of organizations are beginning to buy into it because the notion of community benefit, the notion of community engagement is really now become a recognized metric for many organizations. I mean, I can speak for our cancer center that community engagement is now one of the drivers for NCI designation, as well as a number of the larger healthcare organizations that this is part and parcel of their everyday work. It's going to take time, it's going to take patience, and these activities don't happen overnight. But it begins by bringing together what I call kind of this group of individuals, and then it expands and expands from that.
Great. So I hope it does expand and expand from that. I think that the Cancer Institutes have been a little more forward thinking about this than many other contexts. So you point out that this is now a known phenomenon within cancer. And I think, starting way back with navigation and really now regarding community-based work, it hasn't really spread to a lot of other parts of healthcare nearly as much as maybe it has in cancer. And even there, it still has a lot of room for growth. But with that, congratulations. Thank you so much for kicking us off this year. There were a lot of other questions in the chat, and I hope people might feel that they can send you an email. And
Absolutely.
Yeah. And with that, I'll hope to see people in the next session. Be well.
Thanks, everybody.
Bye-bye.